It is important to know that when we have a therapeutic protein, a drug, that is antigenic, we have a variety of potential structures that we're dealing with. So if you look at this particular cartoon, the first list there, aspirin is not a protein, of course. It's just starting from the size of the aspirin, considering that 1x size, which is 0.18 kilodalton, uh, you can see the proportion of the size just in terms of the molecular weight of the potential drugs that we use that could be produced in bacteria or yeast on the left. And you go from the smallest, that could be a peptide like calcitonin, to proteins and eventually more complex proteins that have no sugars because they are produced in bacteria or yeast. The fact that I'm highlighting the element of sugar is because it adds a complexity to the quaternary structure of that drug, and it does produce potentially more uh, antigenic elements on this particular complex protein. So the more complex it is, the more probability we have of having a particular part or epitope of that drug to be seen as a potential danger signal by the immune system and mount an immune response to it. When we move to the mammalian produced drugs, now we have the addition of potential glycoproteins, sugars added to this protein. And as I mentioned, that adds another level of complexity into the structure of these drugs that can potentially be seen as immunogenic. Now, don't interpret this as saying that the more we go to the left, the less immunogenic they can be. The immunogenic response could be infrequent, but it could be lethal. So the fact that you can have a rare instance of a immune response to a smaller molecule because there's less elements that can actually mount an immune response, it doesn't necessarily mean that that immune response in particular could be dramatic, could be a serious adverse event, and it could be death-threatening event. So the reason why I'm putting this here is just to explain there's a complexity to these drugs, but ultimately the response of the immune system is idiosyncratic, and we need to make sure we can interpret it as, in a case-by-case basis. In order to understand better the interactions between a drug that's a protein drug and antibody function, I just want to go through this cartoon and walk you through it in a logical way. So we normally have a cell with membrane receptors, and you have a situation with a soluble ligand that binds a membrane receptor. So when we use a drug to block this particular interaction, the drug can be either an antibody, depicted here as the green and blue molecule, or it can be a non-antibody protein, depicted here with orange and dark red. And that particular drug can bind either the soluble ligand or the membrane receptor. Now, the important thing that I'm showing in this particular cartoon is where they bind. So let's look at binding the triangular image there, which is the soluble ligand. What I'm putting in here is that the drug is binding precisely the piece of that soluble ligand that identifies and engages with the membrane receptor. So our drug is acting as a true blocking agent of this particular function. On the other hand, if our drug is now binding a membrane receptor, what I have depicted here is a binding exactly in the groove of that receptor that literally is occupying the receiving piece of the membrane receptor, and it doesn't allow the soluble ligand to work. So this is in a nutshell what happens with our drugs that are protein drugs. I just have to mention that the effect of that binding on the membrane receptor does block the soluble ligand from engaging it. But the resulting effect on the cell could be either an inhibition of that pathway or a promotion of that pathway. So depending if we actually have analogs to the endogenous proteins that will engage that receptor and make the cell more active, or we have inhibitors that bind that particular receptor on the membrane and could actually inhibit the final effect that the soluble ligand engagement normally produces. But for the sake of this particular explanation, the important thing that I'm showing here is that the drug blocks the binding of the soluble ligand, the natural soluble ligand, to the membrane receptor. So now we have a drug, which can be an antibody or it can be a protein. And the antibody here is depicted in green and blue, the therapeutic protein in orange and dark red. So it is binding either the soluble ligand or it's binding the membrane receptor. But now we have antibodies to the drug. So when that antibody to the drug is binding the site that is the functional site of the drug, the site that precisely will produce the binding either to the soluble ligand or to the membrane receptor, what happens is that we do not have that blockade anymore. And then the soluble ligand is able and capable of binding a membrane receptor. Both of them are now free to work as usual. So an anti-drug antibody that is binding the functional part of the drug, either an antibody Fab portion or the piece of the protein that actually is binding the ligand or the membrane receptor, this anti-drug antibody will neutralize that particular function of the drug. So it's as if we were not giving the drug at all. The normal interaction will be happening without any effects. And this is the case when we have neutralizing antibodies. Now, antibodies have other functions, not only the binding of their target. And I want to review those functions because they are pertinent to both cases. When our drug is an antibody, we may have other functions of that antibody outside the antibody binding site, which is the Fab portion of the drug. But also, if we have anti-drug antibodies in both cases, these antibodies also have functions that are outside their binding site. So let's review first the complement-dependent cytotoxicity. When an antibody binds the surface of a cell and produces a cluster of receptors of that particular immunoglobulin, then this clustering will bring or will attract the complement complex, and it will begin the complement cascade of events that eventually literally drill a hole in a cell membrane and produce the death of that cell. So that is the complement dependent cytotoxicity or cytolysis. So now I'm going to ask you to follow what I'm saying. I don't have animation for this particular narration, but let's now think that our drug is binding the receptor, but our drug is not an antibody. However, there's an anti-drug antibody to that drug. So the drug is bound to the receptor, and if it's not an antibody, it will not produce a complement cascade. However, if there is an anti-drug antibody to that particular drug that's bound to the cell membrane, we could potentially have a CDC effect that is derived from directly the immunogenicity of that particular drug. So, in other words, anti-drug antibodies could bind outside. They're not neutralizing because they are allowing the drug to bind the receptor. So the anti-drug antibody is binding outside the neutralizing site, but it is binding that particular drug that is engaged with the receptor, and it produces a cluster of receptors that triggers a CDC response, which is not to be expected. So that's the case when we do not have an antibody as a drug. Next, when we do have an antibody as a drug, it's a bit more tricky because it's as if part of the efficacy of that drug may be the CDC activation, like in the case of rituximab. So when you have an antibody to a receptor that will normally be not only binding the receptor, that's the antibody function, but through the Fc portion, it will actually activate the complement cascade and produce the cell death of the lymphoma cells, for instance. So this could be part of your mechanism of action of your drug. And if you have an anti-drug antibody that is not neutralizing, it is acting outside the Fab of your drug antibody. So your drug antibody is capable of binding the target, which is the receptor on the cells. But you have now an anti-drug antibody that could potentially be blocking the area of the Fc portion that activates the cascade of the complement activation. So in this case, your mechanism of action would you be expecting cell death, but by having anti-drug antibodies, you could have less efficacy, and they are not neutralizing antibodies. It's through the complement activation that they are decreasing the ability to have the mechanism of action working. So this is a very important concept because when you do testing, we will see that in part 3 of the immunogenicity series, part 2, I'm sorry. When you look at testing for neutralizing antibodies, all we're testing is the ability to bind the target. We're not testing this ability. But this can cause either loss of efficacy and it's not neutralizing antibody, or it could also have effect on safety. The next function of the antibody that is through the Fc portion is what we call the ADCC. So again, I'm going to be doing the same kind of explanation as before. So we have a receptor on the cell, and let's say that your particular drug binds the receptor efficiently. And now you have antibodies to your drug. So if your drug is not an antibody, it would normally not produce antibody-dependent cell cytotoxicity because this is dependent on the Fc receptor. And the Fc receptor in the effector cell, which is a killer cell that will release cytotoxins, and by those cytotoxins kill the cell, that Fc receptor is only present in antibodies. So when your drug is not an antibody and it is binding the cells, you would not expect that drug to have ADCC effects at all. When you have an anti-drug antibody and your drug is bound to the cell membrane, this anti-drug antibody could actually have an Fc receptor that engages with the effector cell and produces antibody-drug dependent cytotoxicity. So this can happen in cases where your drug is not an antibody. If your drug is an antibody, then this could be part of the drug's mechanism of action. Going back to the example of rituximab, this is one of the mechanism of actions of rituximab also. Not only the Fc portion can activate the complement complex, but it can also bind effector cells and produce release of cytotoxins and kill the cell by that other way. So when we have anti-drug antibodies, and the drug is an antibody that is supposed to have also ADCC as mechanism of action. The anti-drug antibody, which is not neutralizing because it's allowing your drug to bind the target on the membrane. When you have these anti-drug antibodies binding the Fc portion of your drug, they could block the ADCC effect that you would be expecting from your drug. So in this case, the effects on efficacy could be a decrease in efficacy, but it's not a neutralizing antibody. So to have a decrease in efficacy on particular drugs where you would be expecting them to produce CDC and ADCC cytolysis, your anti-drug antibodies could decrease that particular effect, and they could also be non-neutralizing antibodies. They don't need to be neutralizing to block this effect through the Fc portion. Similar situation happens with the other effect of the Fc portion, and this is in the case of an antibody that is binding a soluble ligand. So when you do have the binding of a soluble ligand by, let's go again with the same exercise, you have a drug that is not an antibody. It should not produce phagocytosis, but if you have an anti-drug antibody that's binding your drug that's bound to the ligand, you could actually have phagocytosis activation. This is going to produce certain signs and symptoms of immunogenicity, of course. So this is all immunogenic response to the drug, and these are all dependent on having a humoral response and anti-drug antibody in terms of B-cell humoral response. Now, the other thing on phagocytosis is again the same situation when your drug is an antibody and should be causing phagocytosis and phagocyte activation, and you have an anti-drug antibody that is not neutralizing, so your drug is bound to the ligand, but it is blocking that activation of phagocytes, then you have less phagocytosis and a decrease in the efficacy of this particular drug. So this is complex because we can have several different effects of antibodies, and when your drug is an antibody, you need to make sure that you dissect in your mind all the different steps that are happening so that you can understand how to interpret the data that you are seeing. There's basically five different classes of antibodies, and they are defined by their constant region chains on the heavy chain. So we have the IgG class, the IgE class, the IgD, IgM, IgA. There are features of each of them that are characteristics of these different classification. And you can actually read a lot more in detail about the different features and functions of these particular Fc portions. So now we are talking about the function of the Fc portion, which is the constant region of basically the heavy chain, and that's outside the antibody binding site. So going back to the interpretation of neutralizing antibodies or loss of function, they can actually be detached. You can have loss of function even if you don't have a neutralizing antibody. So when we spoke about the different functions of the FC portion of the antibodies, it is important to identify that on the FC region, there are 5 subclasses of IgG. There's the IgA, IgM, IgD, and IgE isotypes. And the ability to produce antibody-dependent cell cytotoxicity is more prominent with the IgG1, IgG3 subclass. The other isotypes will not actually have the ability to engage through the Fc receptors the killer cells or the effector cells in the ADCC function. The complement-dependent cytotoxicity is going to be basically triggered with isotypic antibodies that are of the IgG3, IgM, IgG1, and to a lesser extent, IgG2 and IgA. So some of these isotypes will not be able to activate the complement cascade. And finally, for the antibody-dependent cell phagocytosis, what you see here is that basically all IgGs can potentially also induce phagocytosis as well as IgA antibodies, whereas other isotypes like IgM, D, and E will not have that effect. So this is important to know only when you have a drug that is an antibody, because that's the one you know for sure which is the isotype. So when you have a drug that's an antibody, you know the isotype and you know what the likelihood of that particular isotype having any one of these activities through the Fc portion is. You characterize that in vitro so that you can follow if this is part of the mechanism of action or if this is something that you want to make sure you avoid. So then it depends on what is the kind of isotype that your drug is. And in all of the package inserts, when you are prescribing a drug for a patient or if you're doing research, you should know what isotype is the drug. And this is going to tell you some information about potential effects of that drug. The complication is when you have anti-drug antibodies because they could block the effects of your antibody drugs if you are expecting these antibody drugs to have any of these Fc portion effector functions. But it also depends on the anti-drug antibody isotype. And that is idiosyncratic. We have no idea. It's most likely polyclonal or maybe oligoclonal response to the drug. So we could have a mix. Each individual is forming an antibodies to the drug, and we do not have control on what is that isotype. So that isotype could easily be one that engages equally well these functions as your drug is expected to do, and then basically, even though it's binding there, it may actually not have an effect on the expected efficacy. On the other hand, if the individual is mounting an immune response with anti-drug antibodies that are of a different isotype class from your drug, the effect that you would be expecting that particular isotype to have may be blocked. On the other hand, when your drug is not an antibody, we really cannot, when we have anti-drug antibodies, we cannot really anticipate what the human isotype of that anti-drug antibody is going to be in all of the individuals treated. So we cannot expect to know if we have to test for one or another. But in part 3 of this series, I'm going to discuss how to generally look at the signs and symptoms that are important and why do we need to follow all of these special potential effects of an anti-drug antibody. Even when your drug is not an antibody, you can have, quote, antibody effects because of your anti-drug antibody.